Interpretation of ECG tracings. Now, some of you guys may have some experience in various duties that you've done in the past, and that's fine. Others may have absolutely zilch, zero, no experience whatsoever. That's okay, because we're going to fill in all the blanks today. But before I really get rolling here, just a reminder that this is what's left in this class with this semester. Today we're doing chapter 11. I'm happy to announce that's the last lecture day in this class on Tuesdays. Next week, you guys know you have open. You're not having to stick around, take a test with Desmond in the morning and wait around all afternoon like you did today for a 2 o'clock class to start that I have no chapters to cover. You may be asking, but John, I would really appreciate if there was a final exam review. That's usually something that you may do prior to the final exam. I will provide some information about things, if I were you, things to look at for the final exam. But I would say this, the final exam in this class, now you've probably heard me say this about some of our other classes, but in this class, 50% of the final exam is coming from today's talk. 50% of the final exam is coming from today's discussion, today's talk. So I'm saying that beforehand, not after, to make sure, hey, pay attention. There could be some Easter eggs or things like that hidden throughout this lecture. Please don't let me sneak them past you. And when it comes to, okay, the other half, what are you going to ask? All right, I will provide a written, I'm not calling it a review because it's not a review, but a written piece that says, hey, if I was you and I was looking back at stuff that we talked about earlier in the semester, what stuff should I look at? What stuff should I narrow my focus to? And that will be provided not today, probably not tomorrow either, but sometime before the end, the Monday evening before the test.
2 hours prior.
That morning.
2 hours? No, at least give you 3. So no, it'll be later in this week. Things to, again, review to make sure you look at that stuff prior to the final exam. But again, 50% of the final exam in this class is coming from chapter 11 on ECGs, what we're about to discuss right now. So please make sure you do pay attention, make sure you do take good notes. This stuff on chapter 11 is not going to be included in the quote-unquote review, right? It's all the stuff from chapters 1 through 10 that we discussed previously, things to look back at. I put this on here too, again, not next week, because we're taking a break next week for Thanksgiving, but the final exam is the Tuesday after, and there is a homework assignment due. Guess what? This is all going to be over the stuff we're talking about today. So make sure, again, you still have 2 weeks before that stuff is due, before that homework assignment's due, but make sure you don't forget about it. Would hate for you to have done so well up to this point and then lose points from a silly, simple homework assignment. So making sure you guys get all of that stuff in there. All right, so let's talk about the ECG. All right, so what is an electrocardiogram? It's an indirect measurement of the electrical activity occurring within the heart. Those waveforms, the squiggly lines, all the stuff that translate and mean something, it's all related to electrical activity. It has nothing to do, and I'm probably going to talk about it in a couple of slides anyways, has nothing to do with the heart's pumping ability or the structure of the heart, nothing. It's strictly looking at electrical activity. So patients that we determine are at risk for some sort of cardiac or heart type event, probably a good patient to monitor with ECGs. A patient who maybe has a history or a past of having a heart attack, a myocardial infarction, for example, may be someone worth our effort to monitor their electrical activity with an ECG. Now there's different types. There's the 3-lead, there's the 5-lead, there's even the 12-lead ECG. What those things mean is it's looking at the heart through different views, different angles. Again, looking at the heart's electrical activity, not the physical structure, anything like that, just the electrical activity. So a 3-lead ECG is going to give you fewer information than, say, a 12-lead ECG. that's going to look at the heart through many other angles, many different angles, to see maybe there's certain spots of the heart where there is some trouble or is some problems. Now for us, the advantage, or for the patient, I guess, the advantage of a 3-lead ECG is they're going to be more maneuverable. The patient can be more mobile. They're not going to be as restricted having multiple leads. So 3 leads, pretty straightforward, pretty simple. 5 leads, a couple extra little spots, couple extra electrodes that are going to be placed on the skin. Again, right arm, right lower quadrant, left lower quadrant, and a V1 lead that's going to be kind of central in the chest, just to the right of the patient's sternum. Okay, so then there's your 5 leads. A 12-lead ECG actually has 10 different electrodes, one placed on each limb, each extremity, so one on each arm, one on each leg, and you'll have 6 precordial leads wrapping around the heart. Again, notice on the left side of the chest. So that V1 that was part of that 5-lead ECG still could remain. V2 is going to be just on the other side of the sternum. V4 is kind of in the mid-clavicular line, 5th intercostal space. V3 kind of fits between V2 and V4. V5 is the anterior axillary line, where V6 is the mid-axillary line. Again, wrapping around the heart. So again, it's going to provide multiple views or multiple angles to look at the heart's electrical activity. Yes, go ahead.
So is there a reason why we also call them EKGs, or is that just like another abbreviation for it?
ECG, it's electrocardiogram. I think years ago we just kind of got lazy, call it EKG. Now I will, and I'm sorry if I do this, and I tried, especially today, I try to be very careful. I'll say ECG, and the very next sentence I'll call it EKG. And that's on me, and I try to, when I'm talking to a group, I try to be careful and use the same acronym. It's still the same thing. It is still the same thing. What we're looking at here is multiple views of the heart. This is the same patient's ECG, but looking at different leads, different angles, a grand total of 12. Here's lead 1, lead 2, lead 3. So these are just the first 3. Here's some augmented limb leads. Those precordial leads that wrap around the heart, here's those 6. So even though there is 10 electrodes placed on the body, it's looking at the heart from 12 different angles. That was always something confusing to people, going, why do they call it a 12 lead when there's only 10 electrodes? Okay, they're looking at the heart from different perspectives, different angles, and it only takes 10 electrodes to get the 12 different views. Now, as a respiratory therapist, depending where we work, depending where you perhaps even visited, sometimes the respiratory therapist actually gets called to perform the 12-lead ECG on a patient. So be mindful. It may be your job, your role, depending where you're working, to have to grab the ECG cart, EKG cart, and sit there and do these these views of a patient's heart. Now, a 12-lead looks at really the heart at this moment in time. So we do the test, we get the result, we take all those extra leads off. The 3-lead or 5-lead could be more permanently on while the patient's lying in their ICU bed or their telemetry bed being monitored the entire time, and those leads will remain on. 12-lead, it's just during this moment in time during this test. So if they feel that the patient's having perhaps some sort of cardiac event, maybe they call for a 12-lead ECG. Just to remind you, you may get called in clinicals to go down and perform actually a 12-lead ECG. And gentlemen, yes, it's a little uncomfortable when you have to put these leads on a female patient. So I always bring another female, whether it's the nurse or ACP or PCT, somebody in there just as a backup. I definitely bring towels or blankets, things to cover up so I can put the leads on and I have to have somebody just exposed at all times. So yes, it's a little uncomfortable for a male when you're trying to do a 12-lead on a female patient. All right, so what's the value? Again, electrical activity related to the cardiac status of a patient. Again, these are patients that typically are presenting with some sort of cardiac condition or something we're trying to just make sure we're monitoring their cardiac condition. It could be used to assess a patient's response to treatment or response to therapy. It could be something we're looking at during our own therapy, the therapies that we, the respiratory therapists, are performing that could perhaps cause some arrhythmias to occur. The limitation, again, and I've already said it, it does not assess the ability of the heart to squeeze or to pump. Okay, it's strictly a look at the electrical activity, not the squeeze of the heart. If my concern is determining how strong the heart's pumping, it's not the ECG that's going to give me information, it's the what? Blood pressure. That will tell me how strong the heart is pumping. Or checking a pulse to let me know, yes, there is a pulse, there is a strong contraction there. But the ECG is strictly looking at electrical activity. It doesn't tell us about the possibility of a future MI. Everybody okay with the word MI? Myocardial infarction, the fancy medical word for a heart attack. Doesn't let us know about the patient having one in the future. Again, still could happen, but again, this ECG for this patient right now doesn't let me know that. So it's important to know. It's one of the very early first things we'll do in an assessment of a patient to assess cardiac status, but there's certain things it can't provide me, it doesn't tell me. All right, so when should it be obtained? Anytime there's signs or symptoms of acute myocardial disease, myocardial issues, whether it's an MI or angina, chest pain, anything like that. Again, an ECG probably would be obtained. Prior to surgery, make sure the patient doesn't have any cardiac issues prior to surgery. Again, it's something you'd rather know on the front end, not in the middle of surgery when the patient's opened up that they must have a cardiac issue. Again, certain respiratory meds can impact a patient's ECG. So we need, and even certain respiratory procedures could impact a patient's ECG. So it's things that we need to be aware of, even when we're not necessarily focusing on the patient's ECG. Some of the things we're performing, giving, or doing to the patient could cause an ECG change or can cause abnormalities with the patient's ECG. All right, these are from the textbook on page 217 about clinical findings that could indicate when an ECG should be obtained. You know, if the patient's complaining of chest pain, obviously we want to rule out, make sure it's nothing cardiac. If they have dyspnea, dyspnea on exertion, orthopnea, what's that word, orthopnea? Orthopnea. Position. Shortness of breath. I'll start it. Shortness of breath when they're lying down. Proximal nocturnal dyspnea. Shortness of breath after they've been lying down for a couple of hours in bed. They were asleep and they woke up short of breath. Hey, those are good words from way back when. I'm going to make myself a note here that maybe there's some questions for the final I can make sure I include. Pedal edema. Swelling where? In the feet, lower extremities. Patient who may have fainting spells, palpitations. Again, they feel discomfort in their chest. Maybe they feel like their heart's skipping a beat, something like that. You know, those could all be indications to have an ECG. Patient with unexplained and persistent nausea, indigestion, especially in a high-risk patient. Again, that could mimic something cardiac. For the patient, I hope it's simply indigestion and not nothing cardiac. Physical exam, unexplained tachycardia at rest. What is tachycardia?
Fast heartbeat.
I hear fast heartbeat, but tell me, fast means something greater than?
100.
Technically greater than 100. So 101 could be considered tachycardia. A heart rate of 100? Normal, right? What's normal heart rate?
60.
Thank you, 60 to 100. This is kind of turning into a final exam review too. Good. Hypotension, which means low blood pressure, decreased capillary refill. What's capillary refill? How do you perform that on a patient? Squeeze a nail bed. It should kind of blanch or turn white. You release and it should pink up within About 3 seconds or less. Patient with abnormal heart sounds or heart murmurs, pedal edema, cool cyanotic extremities, diaphoresis, jugular venous distension, abnormal sensorium, maybe bilateral crackles, inspiratory crackles, indicating fluid perhaps backing up and building up into the lungs. Now, not trying to get too much into this today, even though I will mention some. Tomorrow's talk in the cardiopulmonary A&P class is over cardiac anatomy and functional anatomy of the heart, so there's going to be a lot more of that tomorrow. But to kind of start us off with the cardiac anatomy, again, we should know that there's a total of 4 chambers in the heart. 2 atriums, 2 ventricles. Atriums are at the top, ventricles are down below. The heart is split right down the middle with the septum. The right side of the heart is a completely separate pump than the left side of the heart. The right side of the heart receives deoxygenated blood from the body. The body's already extracted the oxygen that it needed from that blood, so that deoxygenated blood returns to the right side of the heart. The right side of the heart's responsibility is to pump that blood where? To the lungs, to get oxygenated. Now that that blood is oxygenated, it returns back to the heart and to the left side. So oxygenated blood is here on the left side. And then that left side of the heart's responsibility is to pump blood where? To the rest of the body. Okay, so keeping it pretty simple, straightforward, at least for now. We'll go a little more complicated tomorrow. So when the heart squeezes, the heart doesn't squeeze like this, all 4 chambers together at the same time. It doesn't. The atriums actually have to squeeze before the ventricles can squeeze. So again, trying to mimic what we're seeing on the screen, this is really what the heart's doing. The atriums are squeezing blood down to the ventricles squeeze blood and pump it either to the lungs or to the rest of the body. And so even though it may be happening very, very quickly, the heart squeeze is like this, not like this one squeeze of a muscle. The thing we think about when the heart squeezing, that's probably your ventricle squeezing, because it doesn't take a whole lot of effort for the atriums to have to really squeeze that much. If anything, gravity is going to cause that blood to drop from the atriums down to the ventricles. And of course, there's some valves that the blood has to go through that have to open and close accordingly. We'll get to all that stuff tomorrow. Let me get back to the ECGs. All right, so the cardiac muscle, again, just terms here, terminology to not get us confused. The heart muscle itself is known as the myocardium. That's the heart muscle. The heart contraction, the contraction of that muscle is in response to an electrical stimulus. So there is electrical stimulus occurring inside of the heart. Heart's one of the most unique muscles in that it can generate its own electrical impulse, and it can conduct that impulse throughout itself. So again, that's what we're actually looking at on an ECG, that electrical activity that is occurring within the heart. So inside of the heart, there's special pacemaker cells that can generate its own electrical impulse. There's conducting cells that can take that signal and pass it down through other portions of the heart. There's even a duck in the room. There's even myocardial cells, the muscle itself, that can squeeze and then in turn pump that blood out to the rest of the body, or pump it to the lungs, or pump it to wherever it needs to go. All right, so electrophysiology, the electrical conduction system that is found in the heart. So there's a sequence, there's an order. Please make sure you remember and note the order here. All right, so the electrical activity in the heart originates in the right atrium. It starts up here in the right atrium by something known as the sinoatrial node, or SA node for short. SA node, sinoatrial node. Every time our heart beats, that electrical stimulus started at our SA node. Now all this happens so fast, so quickly. The signal doesn't start in the SA node and takes a few seconds to move. No, it's happening within milliseconds. It's happening so quickly. Think about how your heart is beating right now. I know you're excited, you're in class with me, and your heart's probably beating a lot faster, right? A little tachycardia in here, that's okay. There's no test today, you can bring it down. But each time it squeezes, that electrical stimulus is going through the heart. But that signal starts in the SA node. Again, where is the SA node located? The right atrium. The right atrium. How often do you think the SA node normally fires?
60 to 100 times.
60 to 100 times a minute. Let me step back. What's a normal heart rate or pulse rate?
60 to 100.
Gee, I wonder why those numbers are the same. Every time your heart beats, it's because that SA node fired to start it. Okay? So 60 to 100 times is when that SA node is going to fire on average per minute. Now that signal that originated in the SA node in the upper portion of the right atrium is going to send that signal through the atriums, the right and left atrium, and it will all meet. That duct is quit.
I'm sorry.
It's okay.
I thought I turned it down.
Fine. That signal then will meet at the AV node, atrioventricular node. Now the AV node is also located in the right atrium. Lower portion of the right atrium, but still it is found in the right atrium. So the SA node starts here, fires its signal, it stretches around the atriums, and it meets up in the lower portion again of the right atrium. AV node. From there, the signal goes to the bundle of His, H-I-S, bundle of His. It then continues down the right and left bundle branches. Now the signal is over in the ventricle area. And then it goes to the Purkinje fibers. And all of this electrical signal that started in the SA node continues to fire going all the way through in a normal heart, normal electrical conduction. We'll slow it down a minute. So here's the electrical conduction system. Starts in the SA node. The signal goes throughout the atriums. From there, the signal passes at the AV node. Again, notice it's still in the right atrium, lower portion, but still in the right atrium. From there, the bundle of His, left and right bundle branches, and then the Purkinje fibers. And so if the signal starts here and that signal fires itself all throughout the heart, that's why the atriums squeeze first, followed by the ventricles. When it hits that AV node, there is a slight delay to allow the atriums to finish squeezing. So the atriums and ventricles don't squeeze at the same time. So there is a slight delay of that passage of that signal when it hits that AV node. So again, let me go back. What's the primary pacemaker of the heart? What starts that signal? The SA node. Again, how frequently does it fire? 60 to 100 times a minute. Now there are people who can become sick, can have cardiac issues where their SA node occasionally forgets. It forgets to fire. Now, thank goodness for us, we have a backup pacemaker of the heart. That if the SA node forgot to fire, what's the other node? AV node will then take over. Except it can't take over at the same frequency or same rate as the SA node. Notice if the AV node had to fire, how often it would be able to fire. 40 to 60. Now 40 to 60 is better than 0. So it still will fire, but not nearly at the frequency of the SA node. So doesn't mean the patient doesn't need medical attention. Yes, they will need to be seen. That will need to be corrected. But at least temporarily, the AV node can still take over. And so the AV node is known as the backup pacemaker of the heart, where our SA node is the primary pacemaker of the heart. That starts that electrical signal. Questions on the electrical conduction system?
Do we place the pacemakers over, like near the SA node if it goes out?
Yeah, that's okay. And again, not getting too much into pacemakers, external pacemakers, but they do make such a thing. For those that are unaware, a patient who has an SA node that keeps forgetting to fire, they can place a pacemaker inside that patient's heart. There can be internal ones that are implanted. There can be external ones that are applied from the outside, again, temporarily, to fire and send that signal. It would be a horrible thing if you think about it, that if somebody out there has a SA node that is ill, that is diseased, and they happen to be driving their vehicle in the car right next to you on the interstate as you go home. You know, what do you think would happen to that patient if their SA node forgot to fire? What do you think? Take a guess.
They forget to live.
Forget to live? No, they probably, the heart wouldn't squeeze and pump at its normal rate, so they probably would pass out. You know, heaven forbid they're operating a car and driving next to people, because they could clearly take out the road. If you ever wonder, sometimes you'll hear the story, oh, there was an accident, and single car accident, and somebody went off the road, they had a medical emergency. That's the very gentle way to say it. Yes, they could have had a massive heart attack, that's true, but they could have had an SA node problem that forgot to fire, and that's why they kind of passed out at the wheel and crashed into whatever. Okay, so those things can happen. We see those from time to time. And so if you ever hear about a patient having a pacemaker placed, it's because their SA node keeps forgetting to fire. And so I'd much rather have them having a pacemaker that can take over if, again, their SA node was to forget. All right, some terms here. Again, lots of terms here, especially if you've never talked about this stuff before. So the term depolarization. This occurs when the cells are stimulated. Okay? When that SA node fires, it's going to cause depolarization of those cardiac cells. And it's that depolarization that leads to, that electrical activity of depolarization that will lead to the physical, mechanical contraction of the heart, or the heart chamber. Now, repolarization is return of that signal. Return of that. This is the relaxation phase. That's been a long day. Relaxation phase of that cardiac cycle, allowing the chambers to now refill. Okay, so again, we're looking at electrical activity. That's why I'm not calling it contraction or relaxation. That's what should be occurring, but with this particular type of electrical signal or stimulus. What we're going to see appear on the ECG. So you can look at the ECG. Again, it's strictly electrical activity that we're seeing, but you can see when that electrical activity happens, when the heart should be contracting accordingly at that particular point. And we'll look at different examples here. All right, speaking of which, so if this is your normal appearing ECG, this is labeled, that's your P wave. This represents your QRS complex. This is the ST segment. This is the S wave. This is even a U wave that we'll save for a conversation on another day. That's the electrical signals we're going to see. So for example, the very first blip, the P wave, that's when the atriums should be contracting. I'm not calling it contraction because, again, an ECG can't tell us if contraction occurred, but I do know it's the electrical stimulus. That represents atrial depolarization. Atrial depolarization. Make sure you note what these waves and segments that we're discussing here do represent, because I know I'm going to ask quite a few of these on the test in a couple of weeks. So P wave represents atrial depolarization. That's when the SA node is firing, when it starts to fire. That's really what's happening here. And again, as that signal, SA node, AV node, bundle of heads, and so forth, that's what we're seeing here with this electrical activity. So PR interval, the distance between the beginning of the P wave and almost the point of the R wave. Now, we will be measuring time, or I will be providing a time that you're going to be looking at here. The time to go from here to here should not be any longer than 0.2 of a second. As far as distance goes, it's anywhere from 0.1 to 0.2 of a second. We'll look at some of the graph paper and I'll explain how we get time there. But that time frame is extremely short and extremely fast because that signal is going through so quickly. The QRS complex, that represents ventricular depolarization. So here's atrial depolarization. That should be when the atriums are contracting or squeezing. Here's ventricular depolarization. This should be when the ventricles are squeezing. So I said the heart doesn't beat as one single unit. It's one of these things. Atriums and ventricles, atriums and ventricles. Now, width-wise, and we'll kind of see it normally in just a second, normally should not extend more than 0.10 of a second. Meaning the QRS complex, when we look at them on a normal ECG, usually very narrow, very skinny, tall and skinny waveform.
We were always told it was less than 0.12 seconds.
That used to be the old adage. Now it's kind of, and it makes sense because the boxes are the right size to be able to truly see that. But it is moving to a little bit less, a little bit narrower, 0.10. Now the ST segment, is this portion from the end of the QRS to the beginning of the T wave, the ST segment. Again, we'll worry about time later. I didn't include any time on this one, but we'll talk about this in just a second. The T wave, that's the last portion here. So we started with atrial depolarization, ventricular depolarization. T wave represents ventricular repolarization or rest. Here's when the ventricles should be refilling. Now, if we have atrial depolarization, ventricular depolarization, and ventricular repolarization, what did we miss? When do the atriums refill? Where's atrial repolarization? You can't see it on the ECG because it's occurring during this QRS complex. We can't see it because of the electrical stimulus in the ventricles. So atrial repolarization you would not be able to see typically on an ECG. But the other three you can. Okay? One more time. Atrial depolarization, ventricular depolarization, ventricular repolarization. All right, speaking of time, and how do we know if something is less than 0.10 or less than 1.2 or less than 0.2 seconds? It's looking at these boxes. On the ECG, there will be a series of what I'm going to call small and large boxes. Okay, so when you look at the graph paper and you look at the horizontal axis and you look at the width, that's letting us know time. So if this is what the graph paper would look like with an ECG, again, there's going to be small boxes. Each one I'm pointing to a small box, but there's going to be some large boxes here that are basically 5 small boxes together. Each small box represents 0.04 of a second. 0.04 of a second. You take 5 of those together, 0.04 times 5 equals 0.2. So 0.2 of a second. You take 5 of these large boxes, 0.2 times 5, that represents 1 full second of time. Again, remember, these signals are going by so fast, so rapidly. So when we talk about, something can't be more than 0.12 of a second in width, those are 3 small boxes, 0.12. If I say it can't be longer than 0.2 of a second, then it can't be longer than these 5 small boxes when we're looking at time. On the vertical axis, this represents voltage or amplitude, and we'll get into that conversation a little bit more on a different day. All right, so let's look at some ECGs to interpret. Yes, you can have, and let me tell you this, we are looking at the very basic ECGs today. We'll get into a few more advanced ones down the road, but right now we're just looking at the basics of ECGs. So you can see we have a waveform here, and we can see that waveform is superimposed on some of these boxes, right? You can see the small boxes, you can see the large boxes, okay? Small boxes and large boxes. You can see everything on the screen looks fairly uniform. If I was to pick one, what does this represent? What is this called? A P wave. Here's the QRS complex followed by a T wave. And you can see that on every single waveform. So this one looks pretty good. Let me get to something a little bit different. All right, so here we have a normal sinus rhythm. That's what every one of us hopefully is in right now, normal sinus rhythm. If we did some sort of systematic look or view at this, we can kind of look down. Rate should be somewhere between 60 and 100 beats a minute. In case you're curious, how do I know the heart rate by simply looking at an ECG? Well, you have to have a certain length of time to look at. And that length of time, the easiest way, there's a couple different ways to do it, and I'm going to give you this straight up easiest way to do it, is you need a 6-second strip. Now, I'm not going to get tricky on the test. Every strip I give you, whether I actually counted it or not, every strip on that test, I will promise, will be a 6-second strip. I'm not going to give you an 8-second strip or a 3-second strip and let me see if you can figure that out. No, I will give you a 6-second strip. So don't worry about me trying to trip you up there. If I have a 6-second strip, and how do I know this is 6 seconds? Couldn't I start adding these things up? Yes. And did I add these up beforehand? No, I didn't. But if this represents a 6-second strip, let's just say, tell me the number of QRS complexes that you see on the screen right now. 8. Take that number, multiply it by 10. Hey, this patient's heart rate is approximately 80 beats a minute. It's that simple. As long as you have a 6-second strip. Now, if somebody grabbed you a 7-second or a 5-second, then this is not going to work. Okay, it has to be a 6-second strip. So in this example, there's 8 QRS complexes, 8 times 10, 80. And again, I'm using the term approximate heart rate of about 80 beats a minute. The rhythm is regular. Everything about this is regular. These things are starting at the same time, they're the same distance apart. There's nothing abnormal as far as rhythm goes. There's P waves, and each P wave is followed by a QRS complex. Every single one. They look identical. The PR interval, again, if I'm measuring these small boxes for the PR interval, again, somewhere between 0.12 and 0.2 of a second. So between 3 and 5 small boxes.
You said QRS times 10, why 10?
Because 6 seconds times 10 equals a minute.
Oh.
Very good. You're welcome. That was all me. No, I'm kidding. QRS complexes, again, should be fairly skinny. And yes, there used to be a time it was 0.12 of a second. They kind of recently changed that to 0.10. I hate it because I don't have boxes that are 0.10 apart. I got 0.04 or 0.12 if I'm looking at the large boxes. So yes, but just keep in mind, the QRS complexes are very narrow, very thin. I'll give you a couple of examples where they're not so thin and you can see, okay, I can see where that's not normal. So that's normal sinus rhythm. The next two, essentially they appear the same with the exception, they just are not appearing as frequently or as often. This one here is sinus bradycardia. Everything about this is the same. P wave followed by QRS complex. The rhythm is regular. The PR interval is exactly the same. QRS complex still very skinny, still very narrow. The only exception is things aren't happening as frequently as they were in the normal sinus rhythm. If I said, gee, what's the heart rate here? This is a 6-second strip. 40 beats per minute, approximately. 40 beats per minute. But everything is still normal. This could be your patient. This could be you. Any athletes in here, endurance athletes, people that like to go run for long distances? Heaven help you if you can, because I sure as heck can. Somebody who has more of an athletic heart, this could be you. Sinus bradycardia, and there's nothing abnormal about you. There's nothing wrong with you. You just have a very athletic heart. You have good endurance. So sinus bradycardia. This could occur, just to mention here, when we suction our patient. Remember the two ways to do suction? Either shallow suction to the end of the ET tube or deep suction down to meet resistance. We hit the carina, stimulate the vagus nerve. You know what we can cause? We can cause this, cause vasovagal stimulation and cause their heart rate to go from whatever it is, extremely bradycardic. And so this is important for us because we're the one doing the suctioning, right? We're going down. This patient had normal sinus rhythm before we started. We went down, we're hearing the alarm, we look back up and we see this. Well, my response is, get the hell out of their airways. Quit stimulating that vagus nerve. Quit hitting the carina. Here's another indicator why maybe we shouldn't do deep suction. Maybe we should stick with shallow suction. But this could possibly occur, sinus bradycardia. Now the next one's sinus tachycardia. Again, just like normal sinus, it's just happening very fast, very frequently. Again, help me here with my count. 120. Okay, so there's 12 QRS complexes. Again, making my assumption here, this is a 12-second strip. Here's a heart rate of approximately 120 beats per minute. Again, but everything else is still pretty normal. Looks like normal sinus rhythm. Things are just happening way too quickly, way too fast. This is the patient's room you walk into and you say, hey, I'm here to stick you for an ABG. I've never done this before, so please bear with me. And here goes the patient's heart rate, right? No, I never tell them that. When they ask, how many times have you done this? Oh, I'd hate to tell you how many times I've done this. Just hold real still for me. I used to do that. I think I had 2 under my belt when the guy asked. Oh, so I can't even keep count anymore. He was number 3.
Talking about for the day or for my life?
There you go. I like that. In the last 20 minutes or forever. All right, so it's sinus tachycardia. Now let's get to some more clearly abnormal ones. Atrial flutter. Atrial flutter. Just looking at the name, atrial flutter, I'm going to make this a 50-50. Where do you think the problem is? The atriums or the ventricles? Atriums or ventricles? When it's atrial, wink, wink, hint, hint, flutter. So yes, the problem's in the atriums. Okay? Yeah, it probably will. At some point. Whether it's in the coming weeks or later. And you wonder why I mention that, because people still struggle with it. Okay? So, on the ECG, which blip, which waveform represents the atriums?
The P wave.
The P wave. Please remember that. Please remember, it's the P wave. Do you clearly see a P wave? Yes, they're almost in this crazy sawtooth, looks like a saw blade pattern. In between normal appearing QRS complexes. So your ventricles are firing or doing their thing normally. The problem is everything in between, that's the atriums. Again, atrial flutter. It's called flutter because of this very uniform sawtooth pattern. You know, some things you can't even measure because it's hard to identify specifically where certain things are with this. Don't let this part confuse you. Atrial rates being ridiculously high, ventricular rates much slower than that. It's counting each time the atriums are doing one of these, and that's what's happening during flutter, and then the ventricle squeezes like it's supposed to. The atriums are doing one of these. Each one of those little wiggles I'm doing is counting as a beat, even though it's not really one full complete beat.
Is that gonna affect blood pressure or physical?
It could. I'm glad you asked that. Something like this, atrial flutter, could cause blood flow to stagnate, slow down. Patients with atrial flutter. Now let me step back and say for a second, patients in atrial flutter are not in immediate life-threatening danger. We'll get to some that are. They're not in immediate life-threatening danger, but if it causes blood flow to stagnate, what do you think would happen to blood if the flow of it really slows down and just kind of sits stationary for a bit? What could it form? It could form clots. Patients in atrial flutter are more prone to develop pulmonary emboli than someone who's not in atrial flutter because of the stagnation of blood flow. Blood flow really slows down. And again, it's the atriums. Ventricles are still firing like they're supposed to. It's the atriums where blood flow really slows down, clots can form, clots can develop. Now it's not the same, but something similar, atrial fibrillation. So instead of that sawtooth pattern in between normal appearing QRS complexes, you have this crazy chaotic line, but still normal QRS complexes. Again, so the ventricles are doing their thing. The problem, again, just like with atrial flutter, it's in the atriums. It's in the atriums. So flutter is a little more uniform in its craziness. Fibrillation, it's all over the place. It is fibrillating. It is all over the place. It's not giving a good squeeze. Atriums are not giving a good squeeze down to the ventricles. These patients are also more prone to develop pulmonary emboli. They're not in immediate life-threatening danger, but it is a serious condition. Just like atrial flutter is a serious condition. It does need to be addressed, not to be left alone. It may require medication, may require some additional therapy to correct or to fix. I know we see it on TV all the time when they holler out clear and they shock the patient, right? One of the shockings that can be provided is a term known as cardioversion, which is shocking the heart at a very much lower energy level than the person under CPR where we defibrillate and shock the patient. So that's a much higher, stronger energy level for defibrillation, but this patient in AFib or a flutter can have cardioversion, which is applying a shock or an energy level to the heart to try to get them out of this arrhythmia. All right, PVCs, premature ventricular contractions. So here the problem, I forget where, is it the ventricles or the atriums? I don't remember. I'm having a hard time with this one.
You're asking the hard question.
Yeah, I'm asking the hard questions, yeah. You're saying, yes, please ask those questions on the test, right? All right, so premature ventricular contractions. These are abnormal. Again, things could go normal, and then suddenly you have this abnormalness in the ventricles. And they call them a PVC, premature ventricular contraction. Remember I said before, QRS complexes are usually very skinny, very narrow. Here's your patient with a PVC, this very wide QRS complex. I'll give you another one. I like this one better. A very wide QRS complex. Here's your normal. Again, if I just looked at this is perfectly normal. Unfortunately, it's followed by one of these. My guess is the next one probably would look like this. It would be normal, followed by another one that was a PVC. We'll get to these a little bit more in depth down the road, but if you notice this on the screen, the PVC happens to occur every other beat. You know what they call that? Bigeminy. I'm going to throw this one out here. What if it occurs every third beat? Trigeminy. Okay. What if it occurs every fourth beat? I'm making these up. Okay, so bigeminy, trigeminy. So again, those that are occurring more frequently, the potential increase in seriousness. The occasional PVC, the patient would feel symptoms. They would feel some chest discomfort on occasion when they happen to have or throw a PVC. The more frequently they have them, the potential worse it's going to be for the patient, leading to something more serious. Now, without getting too much into this right now, just trying to make sure you can see what a PVC looks like. If on the test I said, circle of the following ECG, circle the PVC. Yes, it's this wide QRS complex. These are normal. These are normal. This wide QRS complex. This wide QRS complex. Now, something to note, patients who are hypoxemic, this is something they can begin to throw. The longer and more hypoxemic they become, they can start to throw PVCs. So that's something we may note as we're trying to set up O2 for my patient. and I'm noticing, was that a PVC? Okay, let me finish putting my stuff together. Boom, there's another one. Is that another PVC? They're starting to occur more frequently. That could become because your patient's becoming more hypoxemic over time. Again, the more frequent see the premature ventricular contractions. All right, now let's step up the game a little bit. Yeah, here's the
Clear.
ones. Here's the one that, okay, this is life-threatening. This is, go ahead and better call the code blue, hit the code blue button, right? So, again, hard to identify many things here. Some folks say, hey, this is like a PVC, but it never goes away. It's always there. Okay, I see it. And PVCs, the more frequently they start occurring, again, left untreated, not doing anything to the patient, you could see it potentially turn into something like this, ventricular tachycardia. Now, like I said, we'll get into a little bit more in depth later. This particular one I'm sharing with you, one of the first things I would want to identify when I see this rhythm is check the patient's pulse. You know, shake them, make sure, hey, are you okay? They're not arousable, you can't wake them up, you can't find a pulse. This is what we're talking about here. So pulseless VTAC. This is, again, yes, we're calling the code blue, we're getting the code team involved, we're getting the AMBU bag, we're starting to bag the patient, somebody's gonna jump on the chest, begin chest compression, somebody's gonna get the defibrillator, get that ready, get that coming into the room to get ready to shock the patient. They need to be taken out of this lethal arrhythmia. And there's many things you can't even assess with this. I'll show you some better pictures later. This just happened to be the one that was in the textbook. But lethal arrhythmia, CPR, chest compressions, intubation, bag valve mask ventilation, getting the ventilator ready. Again, chest compressions, shocking with defibrillation would be necessary here with pulseless ventricular tachycardia.
So the patient had a DNR and they had that, we just like.
Okay, so DNR, and we know this, DNR is a different story. If they have this and they're a DNR, we're gonna let nature take its course and let them pass. The reason, and I don't want to sound cold or cruel or anything like this, but I'll go ahead and say it anyway.
Bring it.
When there's gonna be times we're gonna be present when there's a patient who is gonna be expiring, who will be passing. Maybe it's a patient who was on the ventilator and we've been given instruction to go ahead and extubate and allow natural death. And so we extubate the patient. And again, there's no way to predict. We have suspicions, I know, but there's no way to predict that when I take that tube out, is the patient gonna pass in the matter of 3 seconds, or could they breathe on their own for a bit? And could that time be 2 minutes, 20 minutes, 2 hours? We don't know. Like I said, I may have suspicions based on the patient's health and how they were on the ventilator, etc., but we don't know. And so when those situations presented themselves to me when I had a group of students in the clinical site, I would say, okay, we extubated the patient, we did the terminal wean, we'll put the patient on some O2, we'll help the nurse keep them comfortable. Now let the family have some time. You and I, we can step out, we can walk out. We'll go over here to the monitor and we'll watch this. They may have had the monitors turned off in the room. Again, don't want to freak out the family, but you and I, or me and the group, can sit there and watch the ECG. And it was a good teaching moment, again, for what was going to happen regardless whether we were there or not. And to see the patient start to throw PVCs if they weren't already. To see the PVCs turn into VTAC. To see VTAC occur and saying, okay, the patient was a full code, we would be doing compressions and defibrillation right now. As VTAC continues, then we see it turn into VFib, which is also another lethal arrhythmia. Okay, VFib, another lethal arrhythmia. So don't confuse ventricular fibrillation with atrial fibrillation. Okay, both have the word fibrillation, but do you see any normal QRS complexes? Absolutely not. Atrial fibrillation, you will see normal QRS complexes with waveforms like this in between. This, you're seeing this crazy chaotic line. There's obviously nothing you can identify or point out to be a P wave, T wave, QRS complex, anything like that. This is a lethal arrhythmia. It too would require chest compression, CPR, defibrillation, shocking the patient.
Clear.
Okay, VFib. So there's only 2 lethal arrhythmias we've talked about up to this point. That's pulseless VTAC and defibrillation. Would require chest compressions, would require defibrillation. All right, any questions on VFib?
You said the ventricular tachycardia and the ventricular fibrillation are the ones that we would need to like shock the patient.
Defibrillate, correct, defibrillate. And when I said VTAC, I also included the word pulseless. Patient has no pulse. Again, we'll get into this a little bit more in time. There is such a thing for a patient to be in VTAC and have a pulse. They are different than the patients we're talking about right now today. So that's a different situation, different story for another day. So if it's VTAC, pulseless VTAC. And again, when I say shock, I mean defibrillate. Higher energy level than say cardioversion. This one, probably the easiest one to identify, right? Asystole, flat line. There's nothing there. There is no electrical activity seen. This is considered a lethal arrhythmia. Again, there isn't going to be no pulse. There is going to be no heart rate. I will also say before I get too much into this, number one, make sure the leads are still connected to the patient. I should have opened with that, and I'm sorry I didn't. I just get all, oh yeah, asystole, flat line. What if the leads popped off?
And you're just if you're
And I'm, okay, compressions, come on, you get the bag and call code blue, and the leads popped off. The patient was sweaty, and those electrodes just popped off.
Or they're in the bathroom, they just took their monitor off because they were tired of the wire.
There you go, there you go. That never happens, does it? Right. So, yes, if assuming everything checks out, and unfortunately for the patient, if everything checks out, yes, the leads are on. They even say check a second lead. Don't just rely on the one. Check a second lead. Make sure it truly is. Okay, let's just say it is asystole. There is no pulse. There is no heart rate. What is the treatment for this?
CPR.
CPR, chest compressions, ventilation. But what are you not going to perform?
Shock.
You cannot shock them. If you've seen it on TV, it's because that's on TV, and it makes for good television to say clear, and you get the pads, and I've never seen anybody have the pads sit there and do. In the hospital, the pads are already permanently attached, right? And the clear is clear, and they press a button. That doesn't look good on TV. TV, it has to be a big deal, and the patient come up in the air and open their eyes? What happened? I wish it was like that. It'd be so much better. But with asystole, let me tell you this, there is nothing to shock. When they're in pulseless VTAC or VFib, what you're actually creating is this situation. When you defibrillate a patient, you're shocking the patient out of that rhythm. Really what you're doing is you're trying to put them here, so what could take over and begin to start firing? The SA node. Right here, there's nothing. There is no electrical activity. And it's sad. Yes, we're going to do CPR. We'll do chest compressions. We'll give medications. You know, doing chest compressions to pump that medicine through the body, so hopefully the heart can start working. But this is not, defibrillation is not a pacemaker. It's not going to jump start the heart. It gets the heart out of that lethal arrhythmia it's in.
So with all these other ones, you're just wanting to defibrillate to like make it like regular, like just to fix their pattern and stuff like that.
So the SA node can take over and begin firing like it's supposed to. But with this, there is nothing to shock. Quick story, and I don't want to spend all day talking my soapbox here. One evening, I'm watching television, and I could tell from my chair as I'm watching TV, I can see red lights shining through into my house. And so my wife and I both got up, we go look outside. There was an ambulance parked kind of in front of our house, but just over a little bit. And at the time, we had an elderly couple who lived right next door to us. And we were both like, it's the couple. And so we walked out to our front porch and we look over and realize, oh, they're not at the elderly couple next door, they're across the street. where the elderly couple, her daughter lived across the street. And so we're kind of standing there, again, EMS rescues in the house, and we saw the wife come out. And she knows my wife and I are both in healthcare, so she kind of signals us to come across the street. So we walk across the street, and she was telling me about her husband. The 911 call was for her husband. And so a few minutes go by, they bring him out on a stretcher, and they're doing chest compressions, they're moving him into the back of the rig, and we can see all this going down. The wife said, "Why aren't they shocking him?" She kept repeatedly asking, "Why aren't they shocking him?" Well, at that moment, he had to have been in a systole. There was nothing to shock. Now, that is not a teaching moment or lesson or anything like that. It was, I'm not sure, I don't know. But we knew in our mind what was happening there. But yeah, and so once they packaged him up and took him, he unfortunately did not survive. But that's why he wasn't being shocked or wasn't being defibrillated, because he was in a systole. Now, granted, we couldn't see the monitor from where we were standing, but that was the only reason why they wouldn't have shocked him, because he was in a systole at that point. He had a massive cardiac event and died right there in his living room. Anyways, speaking of cardiac events, cardiac ischemia, now something we could also see on an ECG is specifically looking at the ST segment. ST segment. So here is a normal ST segment. So again, P wave, QRS complex, and then that ST segment from the end of the S to the beginning of the T. Normally, it's perfectly straight, in line with everything else on that baseline of that ECG. What's pictured to the right of it shows that ST segment being depressed. Depression of the ST segment. Now, what could cause depression of the ST segment? Myocardial or cardiac ischemia. What does the word ischemia mean? Lack of blood flow, lack of oxygen in the blood going to the tissue. So here's the heart has become ischemic. It hasn't received adequate supplies of oxygen and nutrients in the bloodstream. And so it could show depression of the patient's ST segment. Something like this, it is possibly a reversible component if treated quickly enough with proper therapy. If it's not, then we may see that depressed ST segment become elevated, seen with a myocardial infarction. So myocardial infarction simply means heart attack. Again, probably started with not enough blood flow getting to the heart muscle itself, but now it's caused the infarction, that muscle to actually go into problems. We would see elevation of the ST segment. You may hear the word STEMI. Anybody works in an ER, you may hear we have a STEMI. Okay, yeah, they're getting front row, right? They're getting past everybody else there with the broken arm and the stub toe and the runny nose. Yep, no, you're getting straight to the front of the line. Because we know time is muscle. Time is muscle. Time is cardiac muscle. Of course, the patient can have additional symptoms: chest pain, radiating pain going down the arm, pain between the shoulder blades, etc., nausea, pain in the jaw, those other additional symptoms, that radiating pain that could occur with a myocardial infarction. But that's ST segment elevation, not to be confused, I'm bouncing back one, with ST segment depression. Both not good. Let me go ahead and clear that up. Both of them are not good, but the elevation is an indicator of myocardial infarction. All right, so just kind of a few other things here to add to this. So assessing the patient's chest pain. So there's signs and symptoms. That's the SNS. So asking the patient when and how abrupt was the onset of symptoms. When did the symptoms start here? What provoked the symptoms? You know, was it they had no issues before, but the second they started running, they began exercising, maybe they weren't in the best shape, and now they're starting to experience this chest pain or chest discomfort. How would you describe the quality of the pain? Is it sharp? Is it dull? Does the pain radiate anywhere? Like I said, generally folks with a myocardial infarction, that pain may radiate down their arm, their jaw, maybe between the shoulder blades, maybe in their back. Again, could experience nausea with that. Giving them a pain scale, 0 to 10, 0 being absolutely no pain, 10 being the absolute worst pain. Where does the pain, that chest pain on that scale indicate to you, the patient? Again, subjective, but still we'd like to know. What's the time frame of your symptoms? Is this something that just started or has it happened over the last week? Again, hopefully for a patient, hopefully it hasn't been a chest pain issue that's been going on for multiple days or weeks. And then asking, what do you think is wrong? Could this be something cardiac? Do you have a history? If you've had issues before, is this the same or any different? We've had patients before that came in going, I know I'm having a heart attack. This is the exact same symptoms I presented with 5 years ago when I had my first one. It's like, holy cow, this is number 2 or number 3 or number 4. I mean, you see patients that are like that. American Heart Association says suspect an acute MI, so an acute myocardial infarction, if the patient is not responsive to nitroglycerin. Not getting too much into the pharmacology, the drugs here, but nitroglycerin is a medication they could put under their tongue. They absorb it sublingually, and it will cause the blood vessels to vasodilate. If the reason their heart muscle is not getting enough oxygen and nutrients could be from the coronary arteries around the heart being clogged. Nitroglycerin is a potent vasodilator to dilate those blood vessels. So if they're not responding to nitro, definitely this is probably an acute MI case. Generally, folks that take nitroglycerin, it's when they experience angina or chest pain. They may sit down, allow that nitro to dissolve, chest pain goes away. Okay, that's not an acute MI. But now it's not going away, that's an acute MI. And again, time is muscle, time is heart muscle. Please remember that it could be your family, it could be your friends one day saying, I'm experiencing it, but I'm gonna go lie down. The hell you are, you're gonna go see somebody. You know, if it's nothing, great, it's nothing. But you don't have time to go take a nap or go lie down. They may go take a nap and never wake up. So again, be a bully and tell them, no, you need to go get checked out. Rather it be nothing than something, and you let them go and take a nap. When again, time is muscle here, especially if it's the heart.
Would be a good nap.
It would be. Unfortunately, long nap. All right, so last couple slides here. So patients with chronic lung disease many times have abnormalities in their ECG. The COPD patient, I know, I always want to say that. Anybody collecting every time I say COPD? Are you okay? Up to a few $100 now? Okay, gotcha. Wait till next semester. I'm going to say it even more. So hyperinflation of the lung, flattening of the diaphragm can alter ever so slightly the position of the heart. So their ECGs could appear a little bit different than the non-COPD type patient. COPD patients commonly have high blood pressure in their pulmonary circulation. They can have right-sided heart failure known as cor pulmonale. That could still affect their ECG and sometimes cause abnormalities there. A few other things here, and I think I've said this already, patients who are hypoxemic could develop arrhythmias. Again, generally, one of the first things is to see the PVC for those patients who are hypoxemic. If we don't correct the hypoxemia, now you start to see more frequent PVCs begin to occur. Adverse effects of medications that we provide to help open up the airways. You know, those medications, those bronchodilator medications that work wonders, that are great, certain side effects of those can lead to certain cardiac arrhythmias. Have I talked, I don't think I have with this group, I'm confusing you guys with the second year group, so I'm gonna bite my tongue and not say anything else, because we'll get to that next semester anyways. With COPD, the patients with hypoxemia worsens during sleep, and again, may increase nighttime dysrhythmias or arrhythmias for these particular sorts of patients. That's why they may wake up, again, they're feeling short of breath, paroxysmal nocturnal dyspnea, they're feeling chest discomfort or chest pain, why they may, call 911 and end up in our ER for us to see and visit with them. And then what do we give? We give a medication and we make it even worse. Potentially. Hopefully we're not, but potentially. All right, questions? So do you think I could pull approximately 25 questions out of what we just talked about?
You're gonna have
25, 30 questions, because the final exam is going to be probably somewhere between 50 and 60 questions in here in this class. 50 and 60, I haven't finished it yet. I need to step back and see how many questions I have, because I just sit there and start writing. And then when it's all said and done, I step back and go, okay, where was I fairly fair on the number of questions? So I need to make sure I haven't given you, if there's 50 questions, I haven't given you 40 questions that were all from this, because I said it was going to be about half, right? Once I do that, then I'll post the review. There'll be a second tab or second thing underneath this chapter, and I'll simply call it Final Exam Review. And it'll be attached there, the things to look at, to review. Again, nothing from today's talk will appear on that Final Exam Review. It will all be stuff from earlier, the things to look at. And already what I've written, I'm going to go ahead and start giving you the list. Terms. Make sure you remember the terms. We already mentioned a few today, so make sure those terms. Orthopnea, what's the opposite of orthopnea? Starts with a P. Platitnia, right. So easy to get those backwards or confused, right? Easy to get those backwards or confused. So I'll give you the list. I'll include it, things to look at, but I know right now, lots and lots of terms. I was looking to see in this class, there's really no math. So thank goodness, in this class, right? I can't say that for the others, but in this class, there's no math. So I don't think there's any math on the final exam. I think, to be honest, I think the only thing that could be interpreted as math related that we did mention in here was pack year smoking history. Pack year smoking, remember that? So that may be a good thing to make sure you look back to be able to calculate. I'll tell you the number of years they've smoked and how many packs they smoked. What's their pack year? That times that. So maybe if you need it to figure out that, maybe that's the only time you would need a calculator for this upcoming test. But other than that. Okay, I do have a few questions for you guys, so let's knock these out. First question, where does the normal electrical impulse originate for each heartbeat? Is that the atrioventricular or AV node, sinoatrial or SA node, bundle of His, or right bundle branch? This is the SA node. I don't think I asked it. Okay, I'll move on to the next one. I won't say anything just yet. All right, everybody okay with SA node? Okay. Why is there a bundle of His and no bundle of Hers?
Period.
Yeah. I didn't name it, so you can't get mad at me, right? I didn't come up with that name. All right, if the AV node was to pace the heart, what would be the ventricular heart rate? 20 to 40, 40 to 60, 60 to 80, or 80 to 100 beats a minute? This would be 40 to 60 if the AV node, because the AV node is the backup pacemaker. But if the SA node was to fire, we know that frequency would be 60 to 100. And of course, 60 to 100 is not even an answer option on this one. All right, next question. What does the P wave represent on an ECG? Is that atrial depolarization or atrial repolarization, or is it ventricular depolarization or ventricular repolarization? This one is A, atrial depolarization. Now, what should occur to the heart muscle after atrial depolarization is contraction. How it's supposed to work. But again, the ECG doesn't tell us that the chamber actually squeezed or contracted. It's simply the electrical conduction. All right, so look at this. Don't blurt it out. Give everybody a chance to take a look at it for a second. So again, asking yourself a few questions. P wave, Curis complex, T wave, is it regular, is it interval? What am I looking at here? So what do you think this is?
VTAC.
This is VTAC, ventricular tachycardia. Ventricular tachycardia. And when you check your patient's pulse, it is 0. What must happen?
Shock.
They need to be defibrillated. plus CPR, chest compressions, back valve mask ventilation, intubation getting ready to be performed, etc.
You call that
Yeah, there you go. Call them out. Call everybody's roll.
I don't care, call now.
Right.
Did anybody check this one thing?
There you go. There you go. All right. So look at this one. I'll give it just a second. Don't blurt it out. Everybody have a chance to take a peek at it. Okay. So if this is your patient's arrhythmia and it's verified, this is actually what their rhythm is. What would you call this?
VFib.
This is ventricular fibrillation, or VFib. VFib. Ventricular fibrillation. The same treatment we talked about for pulses VTAC applies here as well. Defibrillation must occur. Chest compression, CPR, intubation, mechanical ventilation, all that other good stuff would be important here. So when you're rushing to those code blue situations, and I don't know if you've had an opportunity in clinicals or not, but when the opportunity presents itself, one of the first things, obviously there's going to be a lot of stuff going on during these situations, and it can get overwhelming just the scene, but take a look when you get a second and see if you could figure out what was on the patient's ECG. If they are defibrillating, then it's one of two things, VFib or VTAC. But like I said, I know especially students in the very beginning, the first couple of codes you go to, you are focused on what's my job, what's my duty at that moment, and it should be. It should be. If you're going to be responsible for bagging, then obviously you need to be responsible for bagging. If it's bagging plus you guys are getting ready to intubate, then obviously we've talked about intubation and we practice that some, then do your job that's necessary there. If it's chest compressions, which chest compressions can get exhausting, and when we do have a good number of people that are there in the code, even if it may be just a few observers, if you're there, they're going to put you to work, and they're going to say, hey, we need some help with chest compressions. Get in line, get ready to rotate, because chest compressions are exhausting. You may be doing it for 30 seconds or a minute before you need to time out and switch with someone else. But you can't be in the middle of chest compressions going, I'm tired, I got to stop. No, you got to keep going until we're ready to switch. You know, you can give your partner a look going, are you ready? Okay, let's get close, so when we do make that switch, it is almost a seamless switch from folks doing compressions. But don't sit there and be in the middle of compressions going, okay, I'm done, who else wants to take? No. You need to keep going. You need to keep going. I say that and we do laugh, but do you think that's ever happened before? Where a student just said, I'm tired, I gotta stop. No, you don't. You gotta keep going. Yes, I know you're tired, but hang in there. It's another 10, 15, 20 seconds tops before we can get somebody else in there to switch off with you. And trust me, that person's gonna get tired too. So you gotta get ready to go. Okay, I'm back in line. All right, my turn again. You know, get it all loose and ready to go to get ready to do chest compressions. And how about this? You're in the code. There's a fair number of us. Maybe there's 3 of us that are in the chest compression rotation. Everything seems to be going well with the operation of the code, and then you hear code blue, a totally different floor, totally different room.
Oh, hell no.
What happens then?
Drop everything and go to that code, obviously.
And it'll leave this poor guy still in the middle of his code? Sorry, they called somebody else. You're too old. This one's younger. No, then what happens to the code team? Split into 2. Okay, so the 3 folks doing chest compressions, okay, you got it? All right, good luck. We're heading out to go see this next patient. Again, and so maybe somebody else that was doing a different duty, okay, you've got to get in the line here for chest compression, because it's just, they've left me, it's only me left. You know, that stuff unfortunately happens. It doesn't happen all the time, thank goodness for that, but yes, patients don't get together and say, let's all code at the same time. Or wait a minute, they're coding up here, we can't code, you can't code yet. No, that stuff doesn't happen. It happens when it happens, and especially the bigger the hospital, the more patients, the more opportunity for people to go into cardiopulmonary arrest, unfortunately.
They wait until 3 a.m. hour.
Right. Yeah, and it's never the right time. You just got dinner, you just got a chance to sit down and have a snack. And this is bad. And again, I shouldn't share this stuff with you
This happened
guys.
to me the other day. I was about to eat. I was feeling so great, and all of a sudden, like, my food got cold.
Right. I mean, it happens. We have priorities. Yes, the patients are our priorities. We had, and again, I shouldn't share these stories with you
do it.
Guys, are we turned off there? Go ahead,
Cut.
click me off, cut.